When you hear the word diabetes, your mind probably jumps straight to sugar and insulin, right? But what if I told you there's a type of diabetes that has absolutely nothing to do with blood sugar and everything to do with water? Today, we are diving deep into nephrogenic diabetes insipidus, or NDI. It's a really fascinating condition where the body's super intricate water balancing system just goes haywire. So let's get into it. We're going to cover this whole story from the molecules inside a tiny kidney cell all the way up to what this looks like for a patient. We'll kick things off with what NDI actually is, then we'll look at how the system is supposed to work, what breaks down, how doctors figure it out, and finally, how it's managed. All right, so first things first, what is this condition really? Well, for someone experiencing it, it just feels like an unquenchable, relentless thirst. At its core, NDI is really a communication problem. See, the brain sends out this crucial hormone, arginine vasopressin, you'll also hear it called AVP or ADH, and its job is to tell the kidneys, hey, hold on to some water. But in NDI, the kidneys are resistant, they just aren't listening. And this leads to this classic clinical triad of symptoms. Polyuria, where patients produce just massive amounts of very dilute urine, we're talking over 3 liters a day. Polydipsia, which is that intense thirst trying to make up for all the fluid loss. And because they're losing so much water, they're at a huge risk for hypernatremia, which is dangerously high sodium in the blood. Now, you might think something like this is probably something you're born with, and sometimes that's true. But what's so striking here is that congenital NDI, the kind you inherit, makes up less than 10% of all cases. The overwhelming majority, over 90%, is acquired later in life. And the number one cause for acquired NDI? It's the long-term use of a medication called lithium. So, to really get what goes wrong in NDI, we first have to appreciate the absolutely elegant system that keeps our body's water in perfect balance. Seriously, think of it like a piece of high-tech precision plumbing. It all starts in the brain. You have these specialized sensors that are constantly checking how concentrated your blood is, what we call its osmolality. When it gets a little too high, maybe you're getting dehydrated, the brain's posterior pituitary gland releases our hormone AVP. AVP then acts like a messenger, zipping through the bloodstream to the kidneys with one clear command: conserve water. The kidneys obey, they pull more water back into the body, which makes your urine more concentrated and brings your blood osmolality right back to normal. It's a beautiful feedback loop. Okay, let's zoom way in, down to the cellular level, because this is where the real magic is. So ADP, our messenger, is like a key. It gets to the principal cells in the kidney and fits perfectly into the special lock called the V2 receptor. Turning that key sets off a whole signaling cascade inside the cell, which creates this second messenger called CAMP. CAMP then activates another protein, PKA, which gives the final order. It tells these tiny little storage bubbles, they're called vesicles, that are packed with water channels called aquaporin 2 to move to the cell membrane and fuse with it. These aquaporin 2 channels, they are the gates. As soon as they're in place, they open up and water can just rush out of the urine and back into the body. Simple, right? No key, no gates, no water reabsorption. So what happens when this perfectly tuned system breaks down? Well, in NDI, the brain is sending that AVP signal loud and clear. The problem is, the kidney is just completely ignoring it. We can really think about this breakdown in 2 different ways. In congenital NDI, it's basically a hardware problem. In about 90% of those cases, there's a mutation in the AVPR2 gene, which means the lock, that V2 receptor, is broken. The AVP key just can't fit. In other cases, there's a mutation in the AQP2 gene, so the gates themselves are faulty from the start. Now, in acquired NDI, it's more like a software problem. The hardware is totally fine, but something is causing the cell to downregulate those aquaporin 2 channels. It just stops making them or stops putting them into the membrane, effectively removing the gates. So what causes this downregulation? Well, here are the main culprits. Lithium is by far number 1. It actually gets inside the kidney's principal cells and directly messes with that internal signaling cascade, leading to a huge reduction in the AQP2 water channels. Other causes include high blood calcium, which gums up the kidney's ability to create the right concentrating gradient, low potassium, which just makes the kidney less responsive to AVP in general, and even physical blockages in the urinary tract, which can raise the pressure and signal the kidney cells to pull back their AQP2 channels. So you see, whether it's a broken lock from birth, faulty gates, or a signal that tells the cell to remove the gates later in life, the end result is always the same. The kidneys lose their ability to reabsorb water, and you get this relentless flood of dilute urine. Okay, so how do doctors actually figure this out? It is a fantastic example of clinical detective work, really. You start with a suspicion, and you narrow down the possibilities with some very specific tests. The process is super logical. It begins with the patient's story, that extreme thirst and constant urination. The first real step is to confirm that they are, in fact, making a huge volume of dilute urine, which is usually done with a 24-hour collection. Once that's confirmed, the next step is a water deprivation test. This basically challenges the body. You withhold water and see if the body can concentrate its urine under stress. If it can't, you know you're dealing with some form of diabetes insipidus. The final step is the vasopressin challenge, and that's the one that tells you exactly which type it is. And this right here perfectly illustrates the results of that testing. This graph really tells the whole story. You've got urine concentration on the vertical axis and plasma concentration on the horizontal one. So as someone gets more dehydrated, their plasma gets more concentrated. Normally, their urine should get super concentrated in response. That's the normal line shooting way up. But in diabetes insipidus, as you can see from those lower lines, the urine just stays stubbornly dilute. The key moment is when a dose of synthetic AVP, or DDAVP, is given. What happens next solves the whole mystery. This table just breaks down exactly how to interpret those results. In a healthy person, just depriving them of water is enough to make their urine concentrate. Now, in central DI, where the problem is the brain isn't making enough AVP, the urine stays dilute during deprivation, but the second you give them that synthetic hormone, their healthy kidneys jump into action and the urine concentrates dramatically. But in nephrogenic DI, the urine stays dilute during deprivation, and it stays dilute even after you give them the hormone. Here's the bottom line. If giving the hormone doesn't work, the problem isn't a lack of the signal, it's that the kidney isn't listening, and that's nephrogenic DI. All right, so once that diagnosis is locked in, the focus immediately shifts to management. The goal isn't always a cure, but it's about restoring balance, managing the symptoms, and preventing some really dangerous complications. So the foundation of management really rests on three main pillars. First, if you can, treat the underlying cause. If it's acquired NDI from a drug or an electrolyte problem, fixing that can sometimes solve the whole issue. Second, and this is absolutely critical, is ensuring constant access to water. Patients are losing huge amounts of fluid and they have to be able to replace it. And third is a low solute diet. By cutting back on salt and protein, you reduce the amount of stuff that kidneys have to filter out, which in turn actually helps lower the total urine volume. Now this is where things get really clever, and honestly, it sounds completely backward. One of the main treatments for NDI is to use a diuretic, a water pill. I know. How can a drug that makes you urinate help a condition where you're urinating too much? Well, thiazide diuretics work by causing a very slight depletion of your body's total volume. This sends a signal to the proximal part of the kidney, that's the part before the faulty section, to reabsorb more salt and water way up front. This means less fluid ever makes it down to the broken part of the system to become urine. It is a brilliant little workaround. Then you have amiloride, which has a very specific job in lithium-induced NDI. It actually blocks the exact channel that lithium uses to get into the kidney cells in the first place, stopping it from ever causing the damage to the AQP2 system. And this is a super important clinical pearl. For the most common type of acquired NDI, the one caused by lithium, amiloride isn't just some random diuretic. It's a targeted therapy. It directly blocks the mechanism of cell entry. So let's just put all that together. We nail down the diagnosis with the vasopressin challenge test to prove the kidney is resistant. Then we manage it with a three-pronged approach. Fix the cause if we can, hydrate, 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 and then cleverly use diet and those paradoxical diuretics to quiet the whole system down. All right, finally, let's talk about the long-term picture. What are the real risks? And what's the outlook for someone who's living with NDI? So the complications all come directly from that massive urine output. The most immediate and dangerous risk is severe dehydration and hypernatremia, especially if a patient can't get to water for some reason. In babies and kids, this can lead to what's called failure to thrive. Over the long haul, the sheer volume of urine can physically stretch out the entire urinary tract, the bladder, the ureters, even the kidneys themselves, and that can eventually lead to chronic kidney disease. And of course, the constant need to urinate, especially all night long, leads to major sleep disruption and really impacts a person's quality of life. But, and this is a big but, despite all those serious risks, the prognosis is generally pretty good. The key word is management. With a proper diagnosis and a real commitment to staying hydrated and using the right diet and medications, most people with NDI can manage their condition really well and live a full, normal lifespan. So when you boil it all down, nephrogenic diabetes insipidus is, at its heart, a failure of the aquaporin-2 water channel system in the kidney. And understanding this precise mechanism leaves us with a really critical question for the future of medicine. For all the patients who depend on life-saving drugs like lithium, which we know can damage this delicate system, what more can we do? How can we get better at protecting the kidney so that patients can get the treatment they need without having to trade one disease for another?